Hospitals are providers of acute medical services, with an elaborate system where individuals and organizations play a variety of roles. We begin by analyzing the hospital's value net, starting with our customer segment. Patients are the most intuitive example of a customer. However, there are also a variety of organizations and companies that are also customers, as they pay for the patient's care. These include insurance companies, benefactors, and the state and federal government. The federal program Medicare has disproportionate control of the rules and structure of the game. Medicare controls a large percentage of the annual spend on hospital services and as a result can set the pricing that other customers follow. We now shift our attention to the symmetric partner of our customer base, the supplier. Suppliers include the medical staff, administration, and pharmaceutical and medical supply companies. Though a supply company and a surgeon are conceptually very different, they both provide a key service to the hospital that allows them to operate. Hospitals have no shortage of competitors, as freestanding practices such as birth centers, alternative medicine, and physicians' offices also provide services that were once limited to hospitals. On the buy side, they compete for both patients as well as donor dollars, while on the sell side, they compete for market share, medical staff, and employees. Most hospital competitors can also be considered complementers. Each plays a vital role in the treatment of patients. It is common for a single patient to be treated by a hospital, a rehabilitation organization, a skilled nursing facility, and a home care provider during one episode of care. As we move on, we can see that a competitor and a complementor can play mirror image roles for a hospital. For instance, other hospitals might compete for patients and staff, but they also help create the healthcare market, providing more opportunities for individuals to pursue healthcare occupations. The hospital's value net allows us to better understand the game they are in and aid in our understanding of the roles customers, suppliers, competitors, and complementors play in the evolution of the healthcare business.
U.S. healthcare has been on an unsustainable trajectory, with costs spiraling out of control. There is no dispute that we are currently facing a broken system. Yet how to fix it remains a heavily debated topic. Michael Porter, in a 2009 New England Journal of Medicine paper, presents a strategy for healthcare reform toward a value-based system. He proposes a most compelling approach, stating what we need now is a clear national strategy that sets forth a comprehensive vision for the kind of healthcare system we want to achieve and a path for getting there.
And the unfortunate problem we have right now, particularly in the U.S., is that the way the market works is actually not aligned with value for the patient. The competition is one where financial success to the various participants of the system is not equal to patient success. You can have system participants succeed without the patient succeed. And in that situation, the market starts to make things worse and not better. And that's the fix that we're in healthcare. The market has been actually working against us in terms of value improvement because people aren't rewarded for value improvement. The market has been leading mostly to zero-sum competition, where we're essentially trying to take value from one party to another or pass cost onto the consumer rather than actually improve the overall value created. So once again, everything comes back to value. How do we design?
In a value-based system, achieving and maintaining a good health is inherently less costly than dealing with poor health. Our current delivery system is not organized around value for patients. Rather, it rewards those who shift costs, bargain away, or capture someone else's revenues and bill for more services, not those who deliver the most value. The focus has been on minimizing the cost of each intervention and limiting services rather than on maximizing value over the entire care cycle. The big question is whether we can move beyond a reactive and piecemeal approach to a true national healthcare strategy centered on value.
This shows you how big the opportunity is in healthcare. How we could do so much better, how we could create so much better outcomes, and how we could do it so much more efficiently. And this is the opportunity that we're now starting to see happen. In the U.S. now, there are many bundled pricing pilots going on and experiments. We're learning how to do this. It takes some complicated. It's a little more complicated than just paying the same old way, but we'll get it done. Hopefully, we'll get it done.
Geisinger Medical Center is based in Danville, Pennsylvania. Geisinger is the largest rural hospital in the country. They have 67 sites and treat over 750,000 patients. Geisinger is unique in that they are not only a hospital, but they are a health insurer as well. In 2004, Geisinger began a bundled pricing pilot where they combined multiple services into a single bundled price for open heart surgery. They included initial visit, preoperative evaluation, hospital stay, doctor's fees, discharge care, rehabilitation, and they guaranteed to cover any follow-up care or complications for up to 90 days. Geisinger created an innovative system where players share risk and reward. They developed a new approach to delivering high-value care. Financially, everyone did better. Complications went down and quality went up. Everyone made more money. Geisinger added additional services to the bundled care program, including hip replacements, angioplasty, knee surgery, and cataracts.
Medicare is one of the largest customers of hospitals. They are trying to move to a value-based system. Medicare is trying to use bundled payments to change the game, increase the size of the pie, and increase value without additional spending. The value of a hospital can be measured by its impact on the size of the pie if they exit the game. In New York City's crowded market, when a hospital closes, 10% of the total discharges typically vanish. A 1,000-bed hospital has a $20 million estimated value. The problem with the current system can be demonstrated using the value ladder. The value to the customers, Medicare, and the patient equals the difference between willing to pay and the price. The value to the hospital is the difference between the price and the cost. And the value to the supplier is the difference between cost and the supplier cost. Medicare has not seen the desired outcomes for the money it is spending. Their reaction was to drive the price down to at or below cost. Hospitals react by increasing the volume of activities with the largest difference between price and cost. The result is $153 billion in Medicare hospital spending with little value to anyone. Medicare purchases care this way from multiple care providers, from hospitals, physicians, skilled nursing facilities, home care, and rehab. Medicare deals separately with each provider of care. The result is patients are often passed between providers with no single entity coordinating or incentivized for efficient and effective care. The result is $329 billion worth of spending on healthcare, with little value provided. Bundled pricing combines the pies of each provider type. Medicare now pays one price for the entire episode of care for each patient, regardless of the costs. In this arrangement, providers share the risk and reward of successful outcomes
with each other, and with Medicare. The providers as a group guarantee successful outcomes, and if they are efficient, keep a portion of the value. The result is a bigger potential pie for both Medicare, the hospitals, and the other providers.
Will Medicare shrink the pie? Can doctors and hospitals cooperate? Will patients comply? Stay tuned.